Hey, I'm Ashley Campbell, physical therapist here in Nashville, Tennessee. I'm the Director of Rehab at Nashville Hip Institute at TOA. Looking forward to talking today about the use of the PiezoWave on the hip and lower back. So we're going to dive into some various assessments and treatments today. We're going to go over some of the features of the PiezoWave 2T Touch. We're going to look at the T modes specifically and walk through how we set those up and when and why we would use them. So first of all, we have the ramp T mode. So if I come here and use this one that looks exactly like that, like it's ramping up, I tap that, and you're going to have a couple options here. So you have your starting hertz, your ending hertz, and how long it takes to get there. So essentially when you start the treatment, when you turn on the therapy source, it'll start at whatever we set here. So let's just say we want to set it to 4 hertz. And then over the course of X seconds, this is going to go up by 5 up to 30. We can set that. Let's say we want it to go up over the course of 15 seconds. And then where do we want the ending hertz to be? We're going to take that. It can go all the way up to 12. Let's take it all the way to 12. So it's going to start at 4 when we turn on the therapy source. You'll click the therapy source button again. That will initiate the ramp. It'll ramp up all the way to 12 over the course of 15 seconds and remain at 12 until you press the therapy source button again, at which point it'll stop. And when you start it over, again, the same thing will happen. It'll start at 4 hertz. When you click it again, it'll ramp for 15 seconds all the way to 12, and you can continue to repeat that process. I like to use that when we're doing a little bit more of a dynamic treatment over tissues, almost like a myofascial stretch using the device. So that's the 1T mode, the ramp option. And then if we exit out of that, we can use the burst option, which is kind of the play pause button up here. So if we tap that, we're going to set our hertz for the treatment. So let's just say we're going to start it at, or we're going to have it at 6. And then you have your play and your pause settings. So it's how long you want the treatment to be on for, and then how long we want the off time. So let's say we want it to be on for 15 seconds, and then we want it to be off for, let's say, 5 seconds. When I start with the therapy source, I click the button on, it'll be at 6 hertz. At whatever setting intensity we set it at, it'll go for 15 seconds. It'll then pause for 5 seconds, and then it'll resume again, and we'll cycle 15 seconds on, 5 seconds off for the duration. And you just hit the check button, and that will set that for you. Set your intensity right here as you normally would, and then again, just use the therapy source to start the treatment. Expert mode, or the extended screen version of the PiezoWave 2T Touch, and just what the settings are and how they may benefit you in your use of the device. So if we press this top left-hand corner button here that has all the dots on it, it's going to pull up this screen. So you're going to see the extended view, which essentially you can check any one or multiples of these boxes. So if I want to know what therapy source I have plugged in looking at my standard screen, I can tap that box. The positive peak pressure box will tell me exactly what it sounds like on my treatment screen, my energy flux density, and then my treatment duration and remaining treatment time. So if I check all of these and I press the checkbox button, you'll notice that this extended screen comes out over here. It tells me what therapy source I have plugged in, the F7G3 blue, and then my peak pressure, my energy flux density, and then my total treatment time and remaining treatment time. The nice thing about the remaining treatment time is as you're adjusting your parameters while you're treating, that will change based on your frequency changes, and then it'll tell you your energy flux density will change up here as you change your intensity as well. So just some nice extended options over here on this side. Good for documentation and just good for knowing where you're at in your treatment. If we open that screen back up, you can take any one of those off. Maybe you don't really care to know what therapy source is plugged in since you can visually see it. Maybe all you really want is treatment duration and treatment time. We can tap these, and those will just remain on our screen here. And then lastly, when you're in this screen, a few other just things to note. If you press the speaker button, you can change how loud the beeping noise is on the machine. You can look at the statistics of the machine itself, the control unit, as far as how many shock waves have been used, and then how many have gone through the particular therapy source that is currently plugged in. You can change your language on here, and you can do all of that directly from that expert mode button. Today we're going to be going through a quick assessment for individuals who are coming into the clinic with either low back or hip related pain. So we're just going to go through a few weight bearing assessments first. I'm gonna have Casey here bend forward and try to touch her toes. I'm asking her to give me any feedback on any pain that maybe is brought on by these assessments, but we'll go ahead and just have her bend forward, try and touch her toes. And I'm looking at a few things here. I'm looking at the curvature of her spine. Come on back up for me. I'll have her face away from me. Bend forward one more time. From this direction, I'm looking at for any change in her spine angle, any sort of scoliosis or any weight shift she may do with her pelvis. And then come on back up for me. Then I can have her raise her arms straight up overhead, bend backwards. We look again at the curvature of the spine, how far her hips can move forward, and any reproduction of symptoms. And then I'm going to have her face this way and turn as far as she can to the right. And on this, I'd be looking for how much total body rotation is she able to get, and then how much of that rotation is coming from her hips versus her trunk. And then we do the same thing going the other direction. We compare for symmetries on this as well, and again, any reproduction of symptoms. Then I'll have her face me, spread her feet about hip width apart, and just go into a simple body weight squat. So I'm looking for any weight shift that she may do, any deviation of her hips and knees, and her ability to come back up. And then I'll have her go into a single leg position. I just want to look at her balance first, and then we'll look at the other side. And if she's able to do that without significant difficulty, we'll go back to the other side, and I'll just have her do a little single leg mini squat, nothing crazy. Come on back up, and we'll look at the other side. And again, I'm looking for any deviation she may have, any significant instability that may come out from that. And then the last thing we'll do is look at just a lateral lunge. So I'll have her step out to the side into a lunge position. Good. And then you can move this way, step to the other direction. Again, we can look at symmetry, look at pain reproduction there. All right. So the first thing I'm going to do is a quick range of motion assessment of the hips. So I'm going to start here. We're going to bring the right hip up into flexion. I want to get a true assessment of hip flexion, so where the pelvis wants to start to move. If I drive her knee all the way up to her chest, I can get more range of motion, but I'm getting some of that from the pelvis and the lower back. So I just do a quick check of true hip flexion, get an assessment of the end feel, external rotation, and then internal rotation. And I'm looking at range of motion, pain reproduction, and maybe any sort of compensatory pelvic movements, especially when we're dealing with individuals complaining with low back pain. So I'll do that on both sides. Then we'll go into a couple quick special tests that are very common in patients who have hip pathology. So we'll come up into flexion, adduction, and internal rotation, the fader test, and we can do that as a combined movement. Oftentimes those with intra-articular pathology will have significant pain reproduction and some mechanical symptoms with that test. And then we can come into a fader position, or a Faber position, where we drop the hip out into flexion, abduction, abduction, and external rotation here. Again, looking for how much mobility they have, as well as any pain reproduction in the anterior hip, in the posterior spine region, or in the SI joint. And we would repeat those tests on the other side. Now, in intra-articular pathology and with the spine, there can be some difficulty with active straight leg raise. So I'll have her just lift her leg up as high as she can without bending the knee. And I'm assessing her mobility there. I can passively check that. And then I can bring her down a little bit, have her hold that position. And then I just give some gentle resistance. Reproduction of pain in the anterior hip will often indicate intra-articular involvement or potentially some iliopsoas involvement. And oftentimes we'll see weakness associated with that. From there, I'm going to have her roll to her side. I'm going to do a quick check of her lateral chain as far as strength goes. So we'll have her here in a slight bit of extension. Hold this position, don't let me push down. So we're just checking her glutes. We can bend the knee, take out the glute max a little bit, hold this here, get a better check of medius. I can have her come down, lift her foot, do a quick little internal rotation check, and then lift her knee and do a quick check of external rotation in the sideline position. And this is a good way to get some palpation-based assessment. We're going to be talking later about greater trochanteric pain syndrome, so I can easily assess tenderness over the greater trochanter here, as well as the musculature around that area, anterior to it, posterior to it, and then down the lateral chain, which we'll also be talking about today. And then I can have her go ahead and roll to her stomach. From here, I can have her bend her knee. I can again assess external and internal rotation. This is in the hip extended position, whereas on her back I did it in a hip flex position. And oftentimes you'll see some differences in the available range of motion. I can come in and quickly assess passive hip extension to see if we have any anterior restrictions there. And then I can have her lift her leg, hold that position, check hip extension, and then bend the knee, and check hip extension without the hamstrings quite as involved to check her glute max. Good. And then in this position, I'll have her drop in. I'll palpate kind of the deep rotator region, and I ask her to hold this. And I'm looking for, is she able to activate that and maintain some resistance with those deep rotators? All of which are going to be important both in back pain patients as well as various hip pathologies and involvement. And then here, last few things, we'll do some quick springing of her lumbar spine to assess for any mobility restrictions there. Springing over her SI joints to see for pain reproduction. Palpation of the SI ligaments. Palpation of the piriformis. And then some palpation through the gluteals, which we also did in side lying. If needed, we can also look at hamstring attachment at the ischium, and then through the belly of the hamstring medially, and then laterally down the leg. So that's going to be our quick assessment. All of the feedback and the things I get out of that assessment will help drive the treatments as we move forward, and those will be great test, retest after we do some treatment with the PiezoWave. Individuals who come in with some complaints of some localized or focal lumbar spine pain, and even some pain down into the SI joint region. So in these individuals, usually they're going to have complaints of various functional activities, things like forward bending, prolonged standing, prolonged sitting, any sort of prolonged positioning, and usually have difficulty with extension and or rotation. They also will oftentimes have some complaints of pain with springing over the area or unilateral PA mobilization. If it's SI, it'll typically be tenderness over the ligaments or pain with the springing. So we're going to focus on the lumbar spine. I'm just going to get her set up here. We're going to look at kind of L4 region. So we'll find that by coming in on the crest and find that L4. We're going to focus on her right side. And we're going to use the pinpoint focused sound waves here. So in this particular instance, we're trying to get down to the level of the facet and capsule. If we're thinking that there's some disc involvement, you may want to open that space up a little bit by putting a bolster or a pillow under the person's stomach so we get a little bit more flexion. In Casey's instance, she doesn't have a ton of excessive soft tissue or anything. I think I can use the 30 millimeter or 3 centimeter depth here and get to my target tissue. So I'm just going to get clothing out of the way. Again, I'm going to use the 30 millimeter gel pad. Get that set up. And in this instance, I'm going to use the T-mode burst function. So this is going to allow me to treat with kind of an on-off principle. So similar to how patients will oftentimes become less sensitive to something like TENS or stimulation, that can happen too with using the PiezoWave. So what I want to do is I'm going to treat over this area, and I'm going to allow gaps of kind of off time in the treatment. So I'm going to set it up with our T-mode burst. We're going to do 6 hertz. We're going to have an on time of 10 seconds with an off time of 5 seconds. And that'll repeat during the whole treatment until I stop the treatment. Intensity-wise, this is going to be a pretty deep structure. So I'm going to start her around a 4, and we'll see how high we need to go from there. So again, I'm going around that L4. I'm going to find that area, get myself set up, and we'll start. I'm going to maintain that pressure and get some feedback from the patient, get an idea if she's feeling anything there. 0 to 10, what would you give it? 2. Okay, she's giving it about a 2. So now we're in our off phase for 5 seconds. It'll click back on. It's going to be 10 seconds on. While it's on, I'm going to bump her up to a 6. Feeling it more? gonna go off for 5 seconds. And then when it kicks back on, I'm gonna bump her up again another couple notches. So now we've got around an 8. 0 to 10, what would you give it? About a 5. So we're gonna maintain that. And then I'll just ask her to give me feedback if she starts to notice that she has less intensity of that sensation. We can bump up our treatment intensity, or we can just maintain it as is. So this will cycle on and off, 10 seconds on, 5 seconds off for as long as I run the treatment. And generally speaking, if this is her first treatment, I'll do somewhere between 1,500 to upwards of a full 4,000 pulses, depending on the acuity of the pain. If this is a relatively acute situation, I may stick with the lower end. If it's fairly chronic, then I'm gonna go all the way to the 4,000 pulses and complete that. We can use that exact same treatment principle directly over the SI ligaments if those are a source of pain, or over that SI joint. It'd be the exact same, just a different change in location. Right now we're going to be talking about patients who come in with complaints of anterior hip pain. So there can be a lot of causes of anterior hip pain, and we're going to look at a few ways that we can tease that out, and then a couple different ways we can modify and adjust our treatments with the PiezoWave. So if I look at Casey's left hip here, if I twist her hip around and we get some reproduction of symptoms with this fader test, a lot of times we're thinking some intra-articular pathology. That could be labral pathology secondary to femoral acetabular impingement, or some chondral defects. That can also include some anterior soft tissues, because they're kind of getting pinched in that test as well. So if I come in and I palpate and there's some tenderness or restriction there, that may be a factor in some of her pain. When we treat this, remember that the hip joint itself is intra-articular, deep to the capsule, so we're going to use a deeper gel pad. So for this particular one, we're going to start by trying to address the joint, and then we can move out to something more superficial in the soft tissues. So I'm going to start today with using the focused therapy source. And because, again, we're going deep, targeting the hip joint itself, I'm going to use the 30 millimeter or 3 centimeter gel pad. I'm trying to get as deep as we can. So we'll apply some gel here. Get our gel pad on. And then we'll get her positioned so that she can kind of relax during this a little bit more, but we keep the hip joint kind of opened up. So we'll just do a small bolster under her knees. Okay, and then from there, we're going to be up pretty high in the groin. So I'm going to start with about 6 as far as my hertz goes. And I'm going to start the intensity somewhere between 2 and 4, depending on if this is the first time we're doing the treatment. So I'll start at 2, apply some gel. And we're going to use reproduction of symptoms as our guide as far as where we're going to place the actual sound head. So I'm going to start in the general vicinity of where I think we're going to get that. And that's going to be anterior and quite proximal. And we'll go ahead and start. And I'm just going to use the patient's feedback to decide if I need to shift or increase intensity. Are you feeling anything from there? Okay, so we can go ahead and bump up the intensity. And then we'll see if we get a little reproduction. Okay, so she's feeling that there. So I'm going to hang in this location, but I'm going to increase the intensity until we get her up near about a 5 out of 10. Good. Okay. And then I can just maintain that. And a lot of times in this area, the easiest thing to do is kind of take my hands and hold them here so that I don't lose contact once I find that place that's reproducing that. And in this particular case, I'm probably going to treat anywhere from 2,000 to 4,000 pulses, depending on what additional treatments I may be doing in and around this area. So if I'm also going to maybe change to a more shallow gel pad and address the soft tissues more superficially, I may do about 2,000 pulses and then another 2,000 pulses in those superficial structures. And then from there, we would want to go back and retest whatever we used to create symptoms. So we'll get the gel out of there, and we would come back and we'd re-examine our fader testing to see if pain was decreased with that or if we had improved mobility and flexion and usually internal rotation. Right now we're going to be talking about lateral hip pain or greater trochanteric pain syndrome. So there's a lot of different things that contribute to pain over the lateral aspect of the hip, particularly right over the region of the greater trochanter. This could be caused from gluteal tendinopathy or damage to the gluteal tendons, potentially irritation, inflammation of the bursa, or potentially radiated pain from the hip joint itself, and sometimes radiating pain from the lumbar spine. So it's important that we figure out where the true cause of pain is coming from, and we can actually use the PiezoWave as a diagnostic tool to kind of hunt down dysfunctional tissue. We can also use diagnostic ultrasound to find dysfunctional tissue and get accurate depth so we know which gel pad we'd like to use. Today what we're going to do is we're going to get Casey set up here. We're going to do a quick test of her hip strength function. So I'm going to have her hold her leg right here. I'm going to test her strength, and she's got a little weakness there. Is there any reproduction of pain? And a little bit of symptom reproduction, which would start to indicate to me that the gluteal musculature, the gluteus medius and or minimus might be involved. If I palpate directly over their attachment at the greater trochanter, in those with dysfunction related to the glutes, or with true greater trochanteric pain syndrome diagnosis, they will be tender right over that area. So we have a couple of different indications that we're going after the correct tissue here. So what we'll do is we're going to get her set up on her side, and a couple of reasons for this positioning. One, it's typically a position of comfort for the patient. And two, because we want to get to tissue that can be fairly deep, this allows us to manipulate the leg so we can put some stretch on that tissue. So what I'm going to actually do is have her straighten her bottom leg and let this top leg that we're going to treat come forward. This is going to elongate the tissue, kind of stretch it out a little bit so that I know I can get to the depth that I want to be at. And from there I'm going to tuck this, and we're going to find that greater trochanter. Most time the damage that you'll find if you don't have access to ultrasound, the best place to start with the device, with the sound head, is to come right off the greater trochanter just posterior to it. Start there with our placement, and then we'll be able to kind of move around to find the target tissue. So once I get her set up, I'm going to select my my gel pad. And with Casey, because I have her in this elongated position, and just kind of palpating and kind of knowing the depths or the assessed depths that we've seen before in different patients, I'm actually going to go with our 25 millimeter gel pad. And if I have to, if I can't find tissue that's reproducing her pain, I can always switch and go up to our 30 millimeter to get a little bit deeper. But I'm going to err on a little bit more shallow. Throwing that. Get that set up. Get some gel on top. All right, I'm going to start her around 6 hertz, and I'm going to start this one around 4 in intensity. Okay, so I'm going to find that bony prominence. I'm going to come right posterior to it, and I'm going to start. So I'll hang here for a few seconds and see if I can get some reproduction of symptoms. Nothing there, so I'm going to bump her up just slightly. Now she's feeling that. 0 to 10, what would you give it? So she's given that about a 3. I'm going to actually just slightly change my angle, and that intensifies it a little bit. So instead of bumping up right away on the intensity on the machine, I'm just going to change my angle to get a little bit down into the muscle tendon junction. How about there? And then I can bump it up from there. Okay, that's about a 5. So I can maintain that treatment directly here. And for this particular instance, what I'll typically do is start with about 2,000 pulses. I can go up to the full 4,000 pulses that I want to ultimately get to. But a lot of times what we'll find is there's a lot of tension and dysfunction distally down the lateral chain through the IT band. So we'll actually do a little bit of a combination treatment where we're going to treat directly at the tendon, And then we're actually going to switch to using a linear probe, and we're going to use our T-modes to do some more dynamic treatment of the lateral chain. So we'll do that separately. So on this side, in this particular case, I'd start with about 2,000 to 2,500 pulses here, and then we'll do that whole lateral chain with our other therapy source. Once I've completed both treatments, I'll retest my comparable sign to see if she's had improvement in her tenderness to palpation, her strength testing, and then how she feels with any sort of functional impairment, such as walking up and down stairs, squatting, walking, sitting, and those will get us indications of successful treatment.